No, not DP. Okay. Chalo, we'll start with the hands-on. So this is a very good area which I will start to explain on, which is 3/6. Okay. So first, incision planning. First, what we have to see whether we have good amount of keratinized gingiva or not. If keratinized gingiva is good, then we can take a mid-crestal or a mid-palatal incision or a slightly palatal incision.
How do you decide based on the width?
Based on the width of the adequate gingiva. Slightly buccal, slightly lingual, because we want the whole flap to be reflected on one side. We don't want the hassle of assistant having to reflect the flap, because while drilling there can be a problem that the flap particles it may get inside the osteotomy and our integration will fail.
Yes,
so now when I am looking at a case, what I will first see whether it has good amount of attached gingiva. If it does not have good amount of attached gingiva, we need to make some plan to make the attached gingiva over there. Okay, so if it is a completely some phrenectomy is done, some surgery is done, post cancer patients also have this problem. So there we have to have some techniques like free gingival graft or connective tissue graft to make the attached gingiva. But anyhow, in extraction cases which you are doing today, they are having good amount of attached gingiva. How we check attached gingiva is by the pull test. So we check whether that is moving or not, and we have iodine solutions also. Kabhi we apply that. Now we should always have two blades in our inventory. One is 12 and one is 15. Preferably 15C because it is little thinner. And 12B is one which is very good, and even 12D. So 12D is having dual edge. Dual edge means the blade आगे भी कट करता है, पीछे भी कट करता है. So both areas you can do, and you must use 2-3 blades. Nothing to worry. Oh, thank you. So this is the armamentarium. Okay, 50 number blade, and so when we are planning the incision, first of all, always have a habit of holding the blade in 3 fingers like a tripod grasp so that it doesn't rotate. We have flat handles also, we have round handles also. Both are equally good. Round handles are very good for doing circular incision because you can move it around nicely. Flat handles is a little difficult to do the circular incision, but that depends on operator's comfort. So I am holding it. Now very important to have one finger rest. Somewhere you should have some finger rest. Okay, which tooth you are having finger rest also matters, because if this tooth is mobile, the patient is going to have pain. So maybe splint that and give LA also over there. Sometimes we are doing edentulous arch, and if we have given LA only in one spot, the patient will have pain when you are giving finger rest on this. So give LA properly. Then we always want to go from distal to mesial in incision. We seldomly go from mesial to distal, because when we are doing our blade is following from distal to mesial, we can see what we are cutting, but our vision lacks when we are going mesial to distal. And we should have the incision only on sound bone. So if you feel that there is an extraction socket, but for some reason you have to open the flap over here, maybe you can take it slightly lingually. Okay, but very careful in mandibular areas because lingual nerve can get cut. So, and your incision or your blade should be perpendicular to the tissues you are cutting. It shouldn't be like this or like this or like this to gain access. Sometimes we'll tilt the blade. So if you are tilting the blade, it will go beyond the bone. It will create a trauma to the patient, unnecessary trauma. Okay, so I am holding it in 3 fingers. I am placing one finger rest, and we are going ahead. So this is mid crestal, and this is slightly lingual to the crest. Okay, slightly lingual to the crest is preferred because we will not have to open both sides of the flap. So if we are opening only here, we have to open both sides of the flap. But if we are going a little this side on sound bone, then we don't need to open lingual flap. Okay, and it is better if we don't open lingual flap. Lingual flap, if we open too much, and if by chance we are using aorta around the edges, there is chance of emphysema entering because it's a completely open space, and some blood vessels are also there. Some small cover screw can go and fall into that sublingual space. We want to avoid that. So we will start our incision from the mesiopalatal line angle of the mesiolingual line angle of the 7. We make sure that we are perpendicular to the tissues we are cutting, and we are going
Against
full
the bone.
depth. Most important is against the bone, and we are going full depth. Okay. So as I told yesterday, do not hesitate to cut again if required. In some textbook it is mentioned that we should not go again and again over here, but what is important to cut the periosteum. Sometimes in the early stage of career we are fearful of putting pressure with the blade because we feel it will slip somewhere. So with experience you will get how to cut in one go, but if in the first initial stages you can go like this, like this, like this, like this, like this, like this, if you can't go in one direction. But now see, what I am doing over here is not possible in the patient's mouth. See here where my handle is. Opening is not going to be there. That's why you need a 12 number. No, 12 number. 12 number will have a curved edge. So you can start the incision here, okay, and you can do 12D is the best. 12D you can in the mesial area of the 7 also you will have, you can go back a little bit. Okay, with 12D you can go behind also it will cut, and you can cut the interdental area of the papillary area of the mesial 7. Many a times the mesial 7 is tilted, so that becomes even difficult to cut at the exact area at the root level in CEJ level. So that sometimes the clinicians, they will not cut that area, and from that area they will, without cutting that area, they will start reflecting and the flap will tear. So make sure that you are cutting very close to the tooth. Then you come in front, then make sure you are cutting very close to the distal part of the mesial tooth also. Then we give the sulcular incision. So sulcular incision, like this you can put your blade and you can cut this half, okay, and same way you can cut the mesial half.
Till the line angle.
Yes, so this is very important to cut at the till the line angle. So till the line angle of mesio buccal cusp and distal buccal line angle of the premolar I am cutting. Once we have cut, it will automatically start to open this much. Again, go very deep and very nice over here, but be very careful, your blade can slip and it will create a vertical incision either lingually or buccally. So that area we have to be careful. This also area it is good to use a 12 number blade. Okay. Now we have, I think we have done the reflection. Sorry, the incision we have done. There are some other blades. There are some other handles also available where the blade can be turned a little bit. It has a knob, the blade can be turned. That also is very good to give the sulcular incision with the round handle. Yeah. Okay. Periosteal. Bada periosteal. Anyone. Yeah, that is good. So with periosteal, always we start reflecting the mesial and the distal papillary area first, rather than opening the flap directly from this side. We start, because this area is more taut. So how I am doing, like with the probe also you can do. With the probe you can just reflect a little bit, or with the scaler, sickle scaler or a curette, you can start reflecting this area, because sometimes this area is very difficult to reach with the periosteal elevator. So you can reflect that, you can reflect this area, make it loose, and then with the flatter end you can go from the opposite side. Okay, you will never be able to pull the flap like this, it will tear. So go from the opposite side, place a finger rest, okay, and then you push it inside and you open it. Okay, you push it inside and you open. So when you open, it will reflect nicely, very nicely. And then sometimes we also do what? We do suturing of the buccal flap to the mucosa so that it remains open. I used to do it when I had less assistants. So it is very easy. You can just put a simple holding suture, it is known as. You can just put a small suture, a silk suture over here to the cheek mucosa of the patient. So this will stay reflected, very easy. And then you can, so now you have almost reflected almost half of the width, you can very easily see. And then slightly you reflect the lingual. Don't go overzealous on the lingual, because again it will create a lingual pouch where the things can fall and it can create a problem. So this is the way you open the flap. Then you go ahead with your drilling in the center. You mark that point with the probe. That is very good way where you can mark the point with the probe and puncture it slightly where you want to drill. You can just scrape the bone over there and puncture it little bit, or with a round burr you can puncture, and then you can start. So that will create a small depression in the bone where you want to do that. Before that you have to do the bone flattening if required, and then you make the marking. The marking can be made with any drill, diamond drill, contra-angle handpiece, straight handpiece, whatever is preferred to you, make that marking. So that first marking is very important, where you make that mark. Now we come to suturing. So there are multiple types of needle holders. What I prefer is the Castrovigio type, which is this, and you have Mayo Hager. So Mayo Hager is also very good. It is having 3 locks. You can hold it. You hold it with the thumb and the ring finger in both of these rings. Middle finger is on the stock of the instrument, and you use it in a wrist motion. Use the wrist, don't use the hand. Okay. This is more better for thicker needles. Thicker needles means any needle which comes along with 3-0 suture or 4-0 suture, it will be good, or even 2-0 it will be good. But for thinner needles like small round body needle or a reverse cutting edge needle for 4-0 or 5-0, always use Castrovigio, because this one will apply too much force on the needle and the needle will bend. It will bend, it will break. So we don't. It was a delicate thing. Now we have done our surgery. Now we are going to suture. Before suturing, we have to make sure there is no bleeding, active bleeding coming from the flap. Okay. So for that, and there is no remnant of any gauze, any cotton pellet or any components, and nothing is there. We take the X-ray, we confirm the seating of the cover screw and the healing abutment in the implant. Before putting the cover screw and healing abutment, we always flush the implant channel with the irrigant so that any blood clot is out. We can also place Blue M gel. We can also irrigate with any kind of disinfectant you feel is comfortable. I use only saline. I have stopped using betadine, chlorhexidine, hydrogen peroxide on the bone directly because it is not very good. Collagen activity and osteoblasts is not. They don't come to that site very properly. There are more enzymatic problems there. Okay. Now, before suturing the flap, we have to ensure that there is no bleeding, active bleeding occurring. If there is any active bleeding, you can use cautery to control the bleeding. You can put pressure, it will stop, and then you start the suturing. Suturing per se is not the method to control bleeding, unless and until you are having a ligature tie suture around the artery. We did yesterday that. In the case there was greater palatine artery which was oozing a lot. We put one suture in the greater palatine artery area.
You can cauterize also, no? That
We can cauterize also.
But
We can
when
cauterize
nerve is
also.
in the blood, you can cauterize into
We did cautery, but it was too active. Bleeding was there. So we put 2 sutures. Immediately it stopped because it constricts the vessel area. Okay.
And do we have to remove it later after few? Or you kept
No,
it
you can keep it there.
reserved?
You can keep it. It's not going to completely necrose the flap or anything. You can keep it there for a day or two.
Once we tie them on,
No, it's just going to compress. It's not going to. We are instead of holding, how many minutes we will hold?
Yes.
An artery we cannot stop. Yeah. So we.
चिकन खाते वक्त लिवर आर्टरी को डैमेज करके आया था.
Oh,
They almost 48 hours bleeding हुआ था उसको.
48
Afterwards he came to me. Then what I did is I don't have cautery. मैंने बालूर में सब
heat करो.
ले दे के cauterize कर दिया.
इसलिए देखे cauterize कर दिया. So with thermal cautery. अच्छा. So that is also okay. ठीक है. So suture.
चिकन भी डेंजरस होता है कभी.
Suture.
इधर ही है ना.
Sorry. Thank you very much. Okay. So talking on suturing types, there are many.
cases में सर बाल बर्निशर.
We can put.
अच्छा.
लेटेंट हीट आता है लेकिन बॉल बर्निशर से. ये कॉटरी से इतना लेटेंट हीट नहीं आता. लेजर से तो बिल्कुल ही नहीं आता है. That way.
नहीं अगर कुछ नहीं है.
कुछ नहीं है तो we can do that. So with Castrovigio needle, it makes your life very easy. It is available from 1000 rupees to 5000, 10,000 rupees. You can choose the one which is available on Amazon also. It will have a 6-inch or a 8-inch length. Company name is Trust and Care. or Indo Surgicals also has. Many one of them have. Even Gel Dent has, Oracraft has. They are good companies for making instruments. So you can use that. This is having self-locking mechanism. You don't have to lock and unlock it every time. So it's more convenient to open and close this. Okay. Now a little bit on sutures. This is for demo, so we are using a silk suture on a eyed needle, but in the patient we don't prefer any eyed needle, we use only swage needle which is available in a sterile packet. We never autoclave that packet. It is for single use only, otherwise that thread will break completely. Then we have in that monofilament, multifilament. In monofilament we have silk also, which is coated with something to make it monofilament. Actually silk cannot be monofilament from its natural source, right? Multifilament, silk is there, Vicryl is there. Vicryl is a multifilament. Now what is the problem in multifilament? It will attract a lot of bacteria and food when the things are healing. So in GBR cases where we want absolute sterility, we want the no plaque to get deposited at all, there we use monofilament like Prolene, like nylon, like Teflon. Those sutures are having or even silk monofilament. The problem with using monofilament sutures is the ends of the monofilament suture are so sharp, they will hit inside the cheek and it will cause ulceration. So we have to, with a ball burnisher, we can burn it slightly and make a round nodule so that it doesn't hurt. Or you tuck the sutures in the interdental area. Whatever threads are there, you tuck them in the interdental area, or put flowable on the tooth and tuck them inside that flowable. They will stick and it will not come out.
Just an idea. Like, can we use electronic GP cutter which will be having heated surface to?
We can use for doing that little bit. For
Because
burning.
That will be having very narrow tip.
Tip, yeah.
And easy to place also. Wider end you will just insert that, then pull it and heat it. So automatically it will
go. You can put GP, yeah, good idea. You can use GP warm-up cutter. Okay.
It's very handy also.
Rather than burning anything, it is good.
That's very nice.
Good idea. Very good idea. Next, what we can use is mostly what we use in our clinics is silk and Vicryl. Vicryl had two forms. There is a chromic coated Vicryl, which is a rapid Vicryl. So that will resolve. That will start to disintegrate and open in about 7 to 12 days. And the real proper Vicryl polyglactin, which is not coated, it is purple in color, that will resolve in about 15 to 25 days. The knot stability of coated Vicryl is little lesser, so wherever we are wanting the flap to hold for longer, we don't want to use rapid Vicryl. Rapid Vicryl is the coated one which will dissolve faster. So we don't want to use that. In wisdom tooth extractions, in other cases you can use, but where you're doing grafting, you should not use. Where you're doing implant, you can use. But graft one, we have to hold it little better. Then you can go to Vicryl, which is resorbable, but I really don't find any major use of Vicryl unless and until we are having some area where we cannot reach again to remove it, whether when we are using it inside the flap. So yesterday I told you membrane stabilizing suture. So membrane stabilizing suture, you should always use Vicryl because you are not going to open the flap and cut the suture again. So there you can use the normal Vicryl or rapid Vicryl. Normal Vicryl is preferred because it will hold the space there. It will make that area better for about 15 to 25 days. Till then the upper healing is already done. The epithelium healing is almost completed, collagen maturation is already done. So your flap anyhow becomes very stable. So purpose of suturing is to aid in the stabilization of the clot and stabilization of the flap. Never forget that. So if that is not stable, there is no use of doing sutures. Even if after suture it is loose, it will come out, or if it doesn't come out, it is loose, and if it is not approximating the flap edges, there is no use of suturing. The flap edges, what they say, that every 100 microns per day, the epithelial cells will move towards each other in the flap when they are approximated. So if we have a 1 mm gap, it will take 10 days for this thing to occur. So we want it to be as tight as possible every time. Now when we are talking about suturing techniques per se, you always hold it 2/3 away from the tip of the needle, which is the most stable point of the suture needle. Then when you take the bite, make sure you are taking the bite perpendicular to the tissue which you have to suture. You should not take bite like this when you are suturing for the implant. Okay.
will see that. Okay.
You should not take the bite like this or on the side. You should not
can
take
you
bite.
zoom
Zoom. Make it 5x.
5x.
Sorry.
Screen also.
Yeah. So here, when we are suturing the mid-crestal or crestal incisions, don't suture like this. Don't start like this. Okay? Don't start your needle like this. Make sure that you are perpendicular. Okay? So you have to start like this. Where you have to start? Minimum 5 to 8 mm away from the incision line. If you start very close to the incision line, the flap can tear. So you have to start, and where you have to start, you have to have about a good distance between the two knots or between the two entry points. Good distance between the two entry points. So you start from here. Again, you see how the flap is. If it is having any sinus tract, don't suture on through that sinus tract. Okay, because that area is going to be very fragile.
We'll be doing the that sinus tract has to be
Denucleated, yeah, from
So
that
that
air
time it will be fragile.
it will be fragile, it will be too large, it will not hold the flap properly. So you do it from the either sides of the sinus tract. If you have a very thin mucosa over there, make sure you are taking a deeper bite so that you suture properly. So you start from here, you enter perpendicularly, you twist the wrist, okay, twist the wrist and take it out from one flap first. Okay, so in the start, don't do in a hurry. No need to suture both the flaps together in one go. I mean, don't need to pass the needle from both the flaps in one go. And then the other flap. Okay, so in the model it is opening up. In the real life it is not going to open up like this. Okay, sometimes what we see is that from the area where the clinician has entered on buccal flap, in the lingual flap, because visibility is less, that area either comes mesial or distal. It doesn't come exactly on top of it. So if my entry point on the buccal is here, my entry point on the lingual should be here. It should not be here, or it should not be behind. So here we have to be careful. Then how we tie the knot? We first make sure that you are not having too much of thread exposed outside. You must have it little bit outside the corner of the mouth so that you can hold it. Okay, then you take this thread, wrap it around your fingers, so you hold the needle is not falling anywhere. You either the left side or the right side, you hold it, and then you, it's not coming here, थोड़ा zoom out कर दो.
इधर से ले लो.
Okay, थोड़ा zoom out कर दो otherwise, है ना? हाँ कर दो. हाँ. So you hold it and then you wrap it 3 times. So this is 1. Okay, you see a loop. This is 2 and this is 3. Can you see 3 loops here? Then you take it closer to the other thread, grasp it, and you pull this thread. You don't pull this thread. Okay, do pull the other thread closer. And how you pull it closer? You want to make it outside this needle holder, so you pull it away from the needle holder. Okay, so this is the first thread and you tighten it. Now as you have approximated a little bit, you have come closer to the tissues, you change the holding of the thread, you come closer to the knot with the finger also and with the instrument also, and tighten it. Okay, you keep tightening it. So if you have done 3, if you have made 3 circles, your flap will not open up at this stage, but if you have 2, it will start opening up. Okay, so tighten it nicely. Then again, remember from which side you had taken this first thread, first circle. If you had taken from left side, you take it from right side, because it has to be opposite. So you take 1 and you take second one. So 2 is enough. 3, 2, 2. This is my thing, what I do. 3, 2, 2. So I will do it 2 here. Now in silk, this much is okay, because silk has very good knot stability. Any multifilament braided things have good knot stability. But if you're doing rapid vicryl, that is also braided, but we want more knot stability. If you do monofilament, you take 4 or 5 knots. So here I am doing 2. Okay, these 2, take it,
Clockwise,
twist it,
anti-clockwise.
clockwise, anti-clockwise, clockwise, or anti-clockwise, clockwise, anti-clockwise, however you feel. Anything is okay. Anything is okay.
Alternative.
Okay. Then we will hold it about 2 mm from the, open it doctor, 2 mm from the knot, and we will prefer to hold the to have the knot either on one side, okay, not in the middle. So if your incision is here, don't keep the knot on the incision, keep it either on one side. Buckley is preferred because the patient otherwise will keep playing with the with the knot with their tongue. Okay, keep it the other way. Okay, so this is closer to this, the incision is over here and my knot is over here, far away. Okay, so now let me show you what will happen when we have 2 only 2. Okay, so now I am going to suture. Next suture should not be very close to the first suture, it should not be here, because it will create a area of very less gingiva in between, and the suture itself can cause constriction of blood supply. So too many sutures are also not okay, it can lead to flap necrosis. So we will keep it about 4 to 5 mm away, enter perpendicularly, exit from one flap, take it out. Someone has to hold it, I think.
Yes.
This is model, na?
Yeah.
Hold it will happen. फेविक्विक पुराना हो गया, या
फेविक्विक से लगाया था क्या?
फेविक्विक से लगाया था ना, फेविक्विक पुराना हो गया.
Orange peel.
Yeah, no, this is not orange peel. This is silicone gingiva which they used in the lab to make emergence profile. Okay, now we make this. Okay, and on the other side we come. I have taken little deeper bites because we have a flap tear because of the Fevikwik not being held properly. Okay, doctor, hold this a little. Now what happens if we do only 1 and 2? Okay, if we do only 1 and 2, it has higher chance of opening up. Here it's not, it doesn't get that tight, see.
Yes.
It keeps opening up, see.
Self-locking.
Self-locking is not there, see. So
but
when
in silk it does.
No.
this is silk only. It doesn't. In 2 it will not, don't do 2, it's not a, it's not that stable. Okay? So this is loose, this is absolutely loose. Now what generally people will do, another side they will come. Now by the time they are coming, na, this is, see this what is happening, it is opening up. Now 2 they will make on the other side and they will suture like this, see. Now you see this, you see this, and you see this.
I've been doing this by a last.
Big problem.
Like this.
है ना?
Luckily I was not placing implants.
Must be it need not be implant only. It need not be an implant only.
No, but I was doing suturing like this, 2 clockwise,
Two,
anti-clockwise
two,
I
okay.
knew, but 2 I used to do. Suture was to get since they established. That's what happens to basics now. As you start practicing, you try new things, you forget this.
Yeah. So I am going to show again in the how we do 3. Okay. So 1. So this is 1. Okay. This is 2 and 3. Okay. And you hold it. You take it out first so that it doesn't get tight over here. Many times, no, in the groove of the needle holder, that suture will get stuck and it will create problems. And you keep tightening. Now this is a self-locking one. So now this will not become loose. It has already, like it has locked itself. And then you do 1 and
it
to
will
the
go
other
more
side.
towards the ginger
1,
side.
2. Okay. You lock it. So this is very tight. It's not going to come open.
Okay, sir.
My gratefulness to Dr. Ziv Simon from California, where I went and he gave me one book known as Flap Designs in Implantology, from where I learned this. He gifted me this book. I have a autographed book from him, and he taught me this. I'm very thankful to him. He was the only person who was doing it at that time, and it is a life savior. Life savior. This suturing thing, life savior. Good.
What happens while suturing is now, after tying knot, the loose end and the another needle end, is there any set rule key which side we should be pulling it apart? Because what happens in my suture is it after that knot it holds, and when I'm trying to tighten up like slightly, not at the tissue level, thoda sa upar tighten.
First of all, 3. If you're doing 3, this will really not matter because it will stay over there. Okay, but even if you want to do na, just check where that knot is going away. Sometimes it gets right side, so it depends whether you have started on the right side of the loop or the left side of the loop. Whichever side you have started, make it the other way, opposite side. Simple. So if you have started on the left side, you have to come on the right side. If you have started on the right side, you come on the left side. That's the only thing. That will come with practice. But 3, I have never faced any problem. Even if it is rounded, it
In my
will get.
experience, doctor, you use the middle finger and you can point it out like the thread can be
Where we are going.
Stabilize your knot with the finger, and then where you are pulling with the rest.
Before pulling, ma'am, use your middle finger and place it over the near to where you want the knot. Then you pull it.
So now see, now this is for the interdental area. Okay, so interdental papilla, how we will suture? We are going at the base of the papilla, about 5 to 8 mm away from the papilla. Now here, where there is contact, so we cannot pass on top of the contact. So first we'll take it out from one flap. Now here the contact has been opened specifically for everybody to practice easily, but in real life most of the time contact is not open. Then what you do, the second part is not engaging the flap. The second part is actually to go below the contact point. Okay, so I'm not engaging. I went below the contact point,
Pass the
took it out,
needle.
take the suture thread below the contact point like floss, and now the third point is to now engage the palatal flap. So this is a simple interrupted suture for the interdental area. Okay. So this happens very commonly. This thread is here and we pass it from here. So this will not be correct. You have to make sure the thread is not in the way. The loop is not in the way. You take this. So this is now entering from epithelium of the buccal flap to the connective tissue of the buccal flap, coming out, then below the contact point, then connective tissue of the lingual flap to the epithelium of the lingual flap and coming out. Now same way we have to go the other way. So first I will not tie the knot here. That's very important. I have to go back from the lingual side of the contact point to the buccal side of the interdental contact point, come this side, and
on
then
the other side.
then I will start tying the knot.
Say like mesially we
Hold
have
it.
taken the
Hold it.
mesial to the tooth we have started interdental papilla suture. Then while coming back, we have to come back through the distal part.
No.
Or from the same.
No, from same part. Otherwise, you are looping it. It is
You don't have to loop the
it is the sling
Because I
suture
want
which
to
you
make
are.
it clear.
It is a sling suture which you are saying.
फ्लैप को डिस्टली पुल कर देगा वो।
नहीं,
No, that what you are saying is a sling suture.
Won't pass through it.
No, it will pass, but you are doing a sling suture.
Okay.
I'll show you that. Okay.
Because
What you are saying is,
in a case
Huh?
wherein
Hold,
it was 1-1 palatal. I mean, there was resorption on the palatal side. So I opened the palatal flap. I did the management of it. While suturing, I found it difficult a little. Started with the buccal and then passed on to the palatal, and then right from palatal I just went ahead with the knot. So I had to pass it back and then
Very
then you have to pack
disturbing,
it.
sir. It always that will come in contact with the tongue, and patient will be very discomfort with
No,
that.
no, no. He's saying he didn't pass below the contact point. So that then the suture, one thread of the suture lies below the contact point, one lies above.
The
So
other
the
one-
flap is not approximated, it is
Not
pulled up.
Not
No,
above the
after
top.
that
He's
again
not.
I passed it like a floss and put it underneath.
Okay.
I didn't take it.
Take it
back.
that way. But
I
then your
passed it
thread
like a-
can break. If you are passing it like a, it will, no, thread will break. If you are
It did
passing
break.
it. It did break, okay.
Usually it's because we are forcing.
Okay. Then, okay. Now let me show you one more suturing technique, which is sometimes we don't have time, space, something is there where we cannot pass below the contact. So how to manage that? Now what you do is you can do figure of it. So you pass below the take it from buccal, epithelium tissue to connective tissue and towards the contact point in one go, okay? Okay. Now sometimes what we do is, if we have not reflected the palatal flap, if we have only reflected the buccal flap, so how you will come from connective tissue of palatal flap to epithelium? You cannot come. So here you do a figure of 8 interdental where you go opposite. You go from, I have not reflected the palatal flap, okay? So I go from epithelium of palatal flap to the other side connective tissue, and same way directly I will make it below the contact and come out from here.
Will come out without engaging.
Without engaging, no, I have come out from the contact point.
Contact point.
Without engaging the tissue.
I have engaged the tissue. I have just engaged it.
No, buccal tissue you are not.
I have engaged the buccal tissue. I am not engaging here.
That is what
I have engaged.
Sir, I said
नहीं वो thread को divide कर दिया हाँ. Okay, this happens.
braided.
And see what is happening here. Is it forming a 8?
8.
See this. It's forming a 8.
Yes.
See,
It's for it.
this is a 8. You see the 8? This and this. It's not round. It's not a circle. It's a 8. So this will also aid in your flap closing. This is also okay to do if you have not reflected the palatal flap.
Entry point is different, right?
Entry point of the palatal flap is different. अंदर से. ठीक है हो गया. When you are doing, I want to explain one more if we have time. You have time?
पहले देखते हैं जब तक
Correct.
There is one more.
Then shall I take mine?
Sure. Okay, so this if you see very carefully, it has one thread which is going below and it is coming up like this. So it is going below and then it is come up like this. Okay. Okay, we can close this or I can show you a diagram. We can close.
What was her doubt? What did she ask? Shabina,
Shabina, what you asked?
buccal,